I am Valentin Fuster from New York, and it's a pleasure again to attend, at least virtually, the American Heart Association Scientific Sessions of 2021. As usual, we like to spend an hour or perhaps 1 hour and 15 minutes going over the trials that have been presented. And I always like to have key people, very knowledgeable people who can actually talk about their thoughts about each of the particular studies. Well, let me start by saying that in this meeting, there were 26 trials, and we are going to be presenting 9 trials, and then I will comment on 6 more. And basically, we have valvular heart disease, 2 trials, heart failure, we have 1 trial and 2 comments, atrial fibrillation, cardiac arrhythmias, we have 2 trials and 1 comment, antithrombotics, we have 2 trials and 3 trials for comment only. And then what I call 2 extremes of cardiovascular disease, you will see in a moment what it is. And we have 2 studies there. Well, most important is to introduce my colleagues, and I'm very, very pleased to be surrounded by outstanding people. Dr. Athena Poppas, immediate past president of the American College of Cardiology and chief of cardiology at Brown and director of the Lifespan Cardiovascular Institute in Rhode Island. Dr. Joanna Chikwe, who is the chair of the Department of Cardiac Surgery in the Smith Heart Institute at Cedars-Sinai in Los Angeles. Dr. Alexandra Lansky, director of the Yale Heart and Vascular Clinical Research Program and the Cardiovascular Research Center at Yale University School of Medicine in New Haven. And finally, Dr. Usha Tedrow, director of Clinical Cardiac Electrophysiology Program, Cardiac Arrhythmia Service at the Brigham and Women's Hospital in Boston. Fantastic. Having now have made these introductions, we are really going to start into business. And what we are going to do, we'll start with 2 trials that were presented about valvular heart disease, the AVATAR trial and another trial that was sponsored by the Cardiothoracic Surgical Network on tricuspid repair in degenerative mitral regurgitation. So let's begin. The AVATAR trial, or aortic valve replacement versus conservative treatment in asymptomatic severe aortic stenosis. This was presented by Dr. Marko Vanovic. Well, we all know that the watchful waiting for a patient who is asymptomatic with significant aortic stenosis makes all of us very nervous. And this is the reality. And there are studies that have been done about the topic, but never a large study like the one that we are going to present today. Objective, to evaluate the safety and efficacy of early surgical valve replacement in asymptomatic patients with severe aortic stenosis and normal left ventricular function. Well, let me tell you what these patients are. Actually 157 patients from 9 medical centers in 7 European countries that were randomized into elective surgical arm with aortic valve replacement or a conservative treatment arm, watchful waiting with guidelines-directed management. But who these patients were? Now, let me tell you the patients that were considered to have significant aortic stenosis. A Vmax of more than 4 meters per second, or a mean pressure gradient of about 40 millimeters of mercury, and aortic valve area of less than 1 cubic centimeter. And certainly all these patients had a normal ejection fraction of more than 50%, but they did not have symptoms. How they need all went into treadmill testing. And now what they test there, very well done study, by the way. It was considered to be positive, the stress test, onset of aortic stenosis related symptoms, fall in systolic blood pressure of more than 20 millimeters of mercury from baseline, and EKG or echocardiographic signs of myocardial ischemia. So I think I define what type of patients we are dealing with. All these patients are asymptomatic, but frankly, this is a troublesome group of patients. Well, what were the endpoints? The endpoints were a composite of all-cause death and MACE that comprise acute myocardial infarction, stroke, and unplanned heart failure hospitalization. Well, let's move into the results. The results were very striking, actually. I was very impressed. Look, primary endpoint, 45% events in the conservative group, 22% in the group that was treated surgically. Then they divided and they use, let's look at all-cause death only, a hazard ratio of 0.56. Let's look at heart failure hospitalization, a hazard ratio in favor of surgical treatment of 0.32. And let's put together all-cause death and heart failure hospitalization, hazard ratio of 0.40. Well, this is the summary of the trial. This is the largest randomized trial addressing the issue that we presented. Early surgery was associated with lower incidence of primary composite outcome comprised of all-cause death, acute myocardial infarction, stroke, or unplanned heart failure hospitalization. And finally, a final statement. The AVATAR trial demonstrates that preliminary efficacy and safety of early surgical aortic valve replacement in improving clinical relevant composite endpoint is a reality. These findings advocate for early surgery once aortic stenosis becomes significant, regardless of symptoms. Well, Joe, you are a surgeon. You must be very happy here. Are you?
I think this trial really confirms practice for a lot of us who are very uncomfortable sitting on patients. When you get into the operating room, you can barely get a pencil through that aortic valve. It intuitively doesn't seem to be a sensible thing to wait on a patient with critical aortic stenosis. And this trial really confirms what we saw in recovery. These patients do better if you intervene early. And the jury's out on whether that is going to translate into early intervention for TAVR as well.
Very impressive. Athena, did you expect these results?
I guess they're not surprising. And I think it's a really well done trial in that they actually proved that they were asymptomatic. So I think that's helpful. I'm a little less optimistic, I guess, because it's an unusual group. They're pretty young. They're in their 60s. So this probably might not apply to the 80-year-olds that we're dealing with. And they had very low STS risk score. And a lot of the events that were significant were driven by rehospitalization that started after 12 months, or heart failure rehospitalization. So how much more carefully could we watch patients and use the heart failure as the trigger?
Yeah, it's interesting. Usha, some of these patients actually present with arrhythmias. You know, I see patients that are asymptomatic with significant aortic stenosis. You start seeing DPCs there, would you get very nervous?
Yeah, absolutely. And I think they also get conduction system disease very often. And so they have this horrible situation where you're waiting for syncope. They may have very severe aortic stenosis, but they're also developing conduction system disease, periannular fibrosis, and ventricular ectopy or even ventricular tachycardias.
Well, okay, Alexandra, what did you learn, if anything?
So you said something earlier in your introduction that this patient population makes us very uncomfortable. And I think it makes us uncomfortable because it's very difficult to follow symptoms in these patients. We just don't know. And I think, you know, they hide it well because they adapt their functional status to how they feel. So I think that's one issue. And also, you know, this issue of sudden death. So it's anywhere between 1.5% to 6%, depending on whether or not they're truly asymptomatic. So to me, I guess I'm with Joe. I think I'm very encouraged with these results. I think they're consistent with what we saw from the Korean study. As you know, there's an ongoing large-scale randomized trial looking at TAVI that's much more definitive, 900 patients, 10-year follow-up. And I think that's the question is, you know, what is the long-term outcome of these patients? Here it's a 2-year endpoint. It'd be really nice in the surgical space to look at 5 years, 10 years to really understand what the outcomes are.
Well, thank you very much. Certainly is a good study. And I think that it will give a lot of thought to many people. But here comes the second study, also in the field of valvular heart disease, and is entitled, well, in fact, was sponsored by the Cardiothoracic Surgical Trials Network, and is entitled Concomitant Tricuspid Repair in Patients with Degenerative Mitral Regurgitation. And this was presented by Dr. James Gamiait from the Division of Cardiac Surgery at Johns Hopkins. Well, let me start by saying that I think everybody is in agreement that if a patient undergoes mitral valve repair or replacement and there is severe tricuspid regurgitation, these patients will progress. I don't think this is the issue. The issue that we are discussing here are those patients that have moderate tricuspid regurgitation and they undergo mitral valve repair or replacement. And there are two issues that I think make people to be sometimes resistant to touch the tricuspid valve. One is that there is evidence in the literature that many of these patients actually the tricuspid regurgitation regress. And then there is the issue of pacemaker. I don't know, Joe, what are you doing, surgeons over there, but you put lots of pacemakers when you get into the tricuspid valve. And this somehow is where the reluctance is, but the real life says that 5 to 75% of patients undergoing mitral valve surgery actually have tricuspid valve repair. So when it's 5 to 75%, is already telling you there are some doubts by some people, and this is actually why this trial, in my view, is quite meaningful. Let's now discuss the study. The study actually entailed 39 centers, United States, Canada, and Germany, with 401 patients who were undergoing mitral valve surgery for degenerative mitral regurgitation to receive a procedure with or without tricuspid annuloplasty. The primary 2-year endpoint was a composite of reoperation for tricuspid regurgitation, progression of tricuspid regurgitation by 2 grades from baseline, or the presence of severe tricuspid regurgitation or death. It's an interesting endpoint because it's a mixture of clinical things and echocardiographic things, which you don't see normally. I suspect what they try is to get endpoints, I suspect. Well, anyway, this is the story. Now, the patients who underwent mitral valve surgery plus tricuspid annuloplasty actually had fewer primary endpoint events than those who underwent mitral valve surgery alone. Significant, actually, 3.9% events for the dual approach versus 10.2% for the approach of those who only had mitral valve repair. And then we go into 2-year mortality, some difference, 3.2% in the dual approach versus 4.5% in the surgery alone group. Progression of tricuspid regurgitation, that's what it was most significant, 0.6% versus 5.6%. So in these patients with moderate disease, certainly the tricuspid regurgitation, if you do nothing, it progresses in a significant number of patients. The frequency of measured adverse cardiac and cerebrovascular events, functional status, and quality of life were similar in both groups. The incidence of pacemaker was 14% versus 2.5%. And these are the conclusions of the study. This was presented in the New England Journal, it's published in the New England Journal, is among patients undergoing mitral valve surgery, those who also received tricuspid annuloplasty had a lower incidence of a primary endpoint event than those who underwent mitral valve surgery alone at 2 years, a reduction that was driven by less frequent progression to severe tricuspid regurgitation. Tricuspid repair resulted in more frequent permanent pacemaker implantation. Whether reduced progression of tricuspid regurgitation results in long-term clinical benefits, here we only have 2 years, can be determined only with longer follow-up. Well, Joe, I'm obliged to go to you again. What do you think when you see moderate tricuspid regurgitation? Let's not get into the tricky business of what the echo shows, who's doing the echo. This was all centralized. So let's assume that there is such a thing like moderate tricuspid regurgitation.
So before we don't get into the echo, let's get into the echo for a moment, simply because it's so dynamic, TR. So one of the things I think we want people to really understand is that any tricuspid regurgitation is worth making a judgment on. So if you see it on a transthoracic pre-op, if you see it on the intra-op echo, that's worth noting. It comes and it goes, but if it's present, that's as bad as it gets. So what does this trial tell me? First of all, it's a tricky question to answer. That's why it's sort of driven by an echocardiographic endpoint. Really well-designed trial, only speaks to a select portion of patients. I think they screened about 4,000 or 5,000 patients to get 400 in the trial. But yes, this confirms my practice. I repair moderate TR. I'd take a pacemaker or a surgeon that knows how to avoid a pacemaker over severe TR any day of the week.
So you're saying you have to individualize the patient. Is this what you're saying, Jo?
You absolutely do. And one of the reasons you have to individualize them is because of what you highlighted there, the lack of clinical difference at 2 years in patients that had severe TR and those that didn't. I think if you've got an elderly higher risk patient, you don't necessarily need to repair that tricuspid valve.
Yeah, Alexandra, you have a comment?
I think what struck me in this study is the 63%, if I'm not mistaken, were actually mild TR, and most of the benefit was in the moderate TR cohort, right? So that was the group that basically progressed. And I guess for me, it just confirms what our guidelines tell us. It tells us that, you know, if you've got severe TR, you've got moderate TR, you probably should go ahead and fix that. But I don't think it really changes our mind, or at least not mine, in terms of the mild TR. I'd love to get Jo's input on that.
I really agree with you. That's a really important take home from this study at this stage at 2 years. I suspect dilatation will be out of the guidelines in the next iteration, because that didn't drive this endpoint at all.
Thank you, Usha.
I have a question actually for Jo as well. One of the things that comes up in these patients, they have their tricuspid valve repaired, and then a lot of my surgeon colleagues then don't want us to place a lead through the tricuspid valve that they've just repaired, which is a challenge. You know, there are a couple of options for that. For us, you know, we could try to put a leadless device in. We could put a lead in the coronary sinus and not cross the valve, or put a very thin conduction pacing lead in. What would be your preferred pacing strategy for someone you've just repaired like this?
So first of all, I start with the surgery. I do everything I can to avoid traumatizing any of the conduction tissue. And there are techniques that can get a permanent pacemaker rate as low as 2 or 3% in published series with concomitant surgery. So that's front and central. Secondly, time. I think we don't wait long enough. We're very keen to get these patients discharged, and that can also often drive a higher pacemaker rate. I'll be fascinated to see if the German sites that seem to have lower pacemaker rates but longer times in hospital, if that's part of the issue. And fourthly, how you manage sort of the antiarrhythmics. But in terms of, you're absolutely convinced you need a pacemaker, I really do like the idea of leadless at the moment. So I think that's a great potential solution for these patients and gives them time to recover safely.
Thank you. Athena, Athena, the last word.
Well, I would agree. I think this was an important trial that really does help answer a question. And there was obviously equipoise given the range of variability that's out there. And as an echocardiographer, I'll come back to that point. And one of the take-home messages for the imaging community is we have to be a little more cautious and careful about grading that tricuspid regurgitation, taking the time to look at the right side and the right ventricular function, which we know can predict progression to TR without or with a ring. And so coming back to some of the findings that this was a core lab, so making sure that we have the correct data to help inform the surgeons.
Okay, thank you very much. Good discussion, but look, we are at the beginning. So take a deep breath in and let's move on. Now comes one study in heart failure, and there are 2 other studies just for comment. The study I'm going to be we are going to be addressing is the emperor preserve type of studies. In this case is entitled empagliflozin in heart failure with a preserved ejection fraction of equal or more than 50%. Dr. Stephen Anker is part of the program from Berlin, actually presented the study. This study is difficult to understand unless one goes to the recent paper published in the New England Journal of Medicine. It is the same type of patients. And the critical issue is what is different in this study versus what was published a few weeks ago. Well, let me go to a few weeks ago, and then it will be easy to understand. The study that was published a few weeks ago, it started with an introduction saying we have very little for patients with heart failure and preserved ejection fraction. And therefore, everything we learn is in patients with reduced ejection fraction. But let's use this drug, empagliflozin, in the so-called Emperor Preserve study. And they decided to do a double-blind study with about 6,000 patients with class 2 to 4 heart failure and an ejection fraction more than 40%. This is important, to receive empagliflozin 10 milligrams daily or placebo. And the primary outcome was a composite of cardiovascular death or hospitalization for heart failure. Follow-up 26 months. Primary outcome event occur in 13.8% in the empagliflozin group and in 17.1% in the placebo group. And mainly of the two endpoints or the double endpoint, which was actually hospitalization or cardiovascular death, really the good results were related to the hospitalization for heart failure. These patients were diabetic or non-diabetic. And actually, in the summary of the paper in the New England Journal of Medicine, they say empagliflozin reduced the combined risk of cardiovascular death or hospitalization for heart failure in patients with heart failure and a preserved ejection fraction, regardless of the presence or absence of diabetes. And then there is a point there inside that says this benefit was consistent across pre-specified ejection fraction groups. But that's the key. It was not presented. It was just few words in the discussion. And this is the paper that is presented today, was presented in the American Heart Meeting, which is what happens when you stratify the ejection fractions. What we presented is more than 40%, but what happened between 40% and 50% or more than 50%? And this is actually what we are going to be discussing. And let me see if I can summarize this very, very briefly. Actually, I can summarize the results because you already know what the study was about. When they look at ejection fraction of equal or more than 50% overall, that is not between 40 and 50%, more than 50%, the event rates in the empagliflozin group was 6.7% per 100 patient years. The results in the original study in New England Journal, they put 2 years altogether. Here is per year, 6.7% in empagliflozin group, 8% in the placebo group. The results were significant. Okay. Then we go into the patients who had ejection fraction between 40 and 50%. The results were actually more significant. 7.2% for empagliflozin, in placebo 10%. So both groups were significant. Then we look at patients with ejection fractions more than 65%. The results were not significant. So basically what we are saying is lower is the ejection fraction, you get better results. But the results are still good between 50% and 65%. And certainly better between 40 and 50%. So they also look at the quality of life by the approach, by the Kansas approach, and was significantly better, certainly in the group that was treated with the drug, with empagliflozin, regardless of the ejection fraction. And then what they look is other studies on ejection fraction, that is with heart failure and preserved ejection fraction. And basically what they say, the Emperor is the best of all the studies being done. So here is the final statement is the primary endpoint, 17% reduction, significant. Hospitalization for heart failure, significant. Quality of life, significant. And also mentioned kidney function. Also the progression of kidney dysfunction was decreased. So in summary, this is the first large-scale study to document meaningful and significant improvements associated with drug therapy in patients with true heart failure and preserved ejection fraction. Well, certainly is interesting. Athena, what do you think about it? Are you excited?
Excited that we saw the differentiation between the groups, and again, this is a very challenging group clinically to deal with. They're a mixture of different diseases, so I am excited to see that this, not surprisingly, the stronger effect is in the lower ejection fraction, but we've had a conundrum around this sort of mid-range ejection fraction, if you will, and what to do with them. So it's encouraging that we saw some positive results there. Looking at all the other comorbidities that play into heart failure preserved ejection fraction, is probably something that we still need to work on. Just perhaps the diuretic effect was what we were seeing the most effect in.
Okay, Usha?
I think it's interesting. I think that it's a little bit disappointing that there's not more benefit the better the ejection fraction, because I think that's the larger patient population. So we sort of wished we had a therapy for them.
Okay, thank you, Joe.
This patient population represents a pretty small part of my practice. It's always encouraging to see a well-designed trial that seems to present fairly robust evidence in favor of a treatment for an underserved patient population.
Thank you, Alexander.
I think it is very exciting. I mean, this is like the first randomized data that we have for therapy in a patient population that we really don't know how best to treat. The outcomes are not good in patients with, heart failure and preserved ejection fraction. So for me, this is the beginning of, I hope, a lot more evidence in this patient population. And I'm very encouraged that we have at least one drug that has shown to be beneficial. So I'll take it. I like it a lot.
Yeah, although the differences were not so great, but they were significant. And I think this is certainly is the first type of drugs, well, not the first. Neprisilin did something also, but perhaps less striking. And mineralocorticoid inhibitors, they say they do something, but certainly less striking. Well, thank you very much. Now I'm going to make two comments. The first comment is about the paper called the Impulse trial, empagliflozin in patients hospitalized for acute heart failure. Basically, this is the story. Everything that we know today about these SGLT2 inhibitors is actually in patients with chronic heart failure, with or without diabetes, and with a low ejection fraction, and also with dapagliflozin, and etc. Today, we learn about the preserved ejection fraction story, but there is one group of patients that has not been studied well. What about if the patient presents with an acute heart failure to hospitalization, or the patient had a stable heart failure and suddenly deteriorates? And this is actually the Impulse study presented today in JACC. And what they show is what we already learned with chronic heart failure. They show actually a benefit in terms of the combination of mortality, all types of mortality with hospitalization, re-hospitalization. They show an increase in the quality of life and so forth. So I didn't think it was necessary to go over, but certainly it is interesting that these drugs appear to be quite important in any patient that presents with heart failure, certainly with reduced ejection fraction, also with preserved ejection fraction, and also patients with acute heart failure. And the other comment I want to make is about this other study called the Chief HF study, canagliflozin, impact on symptoms, physical limitations, and quality of life. This study actually very basically is in patients with different types of heart failure. Most of them is with reduced heart failure. And through access to the iPhone or Samsung S7, and then wearing all these devices, they look at how is the quality of life of these patients, was all done virtually. And actually what they show is with the use of this drug, which has is SGLT2 and SGLT1 inhibitor, actually the improvement in quality of life is significant. And actually what is interesting, it starts at 2 weeks. The other issue that perhaps I would like to comment is that the results of the SGLT2 inhibitors, actually in terms of clinical events, are already apparent at 1 month to 2 months. So the drugs work very quickly. And this is why there's a recent study in JACC actually last week pointing out that we should start these drugs when the patients come to the hospital, because we may do good already in a very short period of time. Any comments, any of you, about these two studies?
I have a comment on the last study because I thought it was also interesting from a method standpoint in that they did EMR recruitment. They did all of this remotely. And so I think it also helped inform us that there may be newer ways, particularly when we're looking at quality of life. They sent things directly to the patient, the Fitbits and whatnot. So as a methods paper, I thought it was interesting too, as a way forward.
We have more to say about these, actually. There are lots of things that are virtual these days. Well, anyway, I think if you allow me, let's proceed into now a third group of papers, atrial fibrillation and cardiac arrhythmias. And we will comment on 2 papers and then a very short comment on a third one. Let me begin with this one, the so-called the PALAX trial. This is a posterior left pericardiotomy for the prevention of atrial fibrillation after cardiac surgery, an adaptive single-center, single-blind randomized controlled trial. Well, it's interesting. As you know, atrial fibrillation following cardiac surgery is quite frequent. 20% of cases to 40%. This is the reality that we all have seen. And actually, it has been pointed out by previous preliminary studies that maybe the pericardial effusion in some way affects the rhythm, the disturbance, or it disturbs the surroundings, and this is why the atrial fibrillation evolves, or perhaps a change in the remodeling of the heart. But anyway, this is a reality. And the hypothesis was, let's do a pericardiotomy, a surgical maneuver that actually drains the pericardial space into the left pleural space. So the fluid that could be harmful there, actually it goes away from the pleural cavity. And this might reduce the incidence of atrial fibrillation. Well, all of this was preliminary studies made some suggestions, but this is actually a very important informal study, or formal study, I would say. And this is the study. This was a randomized controlled trials in which adult patients aged more than 18 years undergoing elective intervention on the coronary arteries, aortic valve, or ascending aorta, or a combination of these, actually entered into the study. And these patients were eligible if they had no history of atrial fibrillation. They were randomized 1-to-1, stratified by the JACC and by other randomization schemes. And they were randomized into posterior left pericardiotomy or no intervention. And patients were followed up until 30 days after a hospital discharge. And they were under continuous rhythm monitoring during the time that they were in the hospital. The primary outcome was the incidence of atrial fibrillation during post-operative in hospital stay. And again, these were continuously monitored. Okay, these patients were recruited between 2017 and 2021, and they screened 420 patients, and they were randomized half and half, as I mentioned. Now, what are the results? The results were as following. In the intention to treat population, the incidence of postoperative atrial fibrillation was significantly lower in the posterior left pericardiotomy group than in the non-intervention group. Actually, it was significant, 17% versus 32%. We can go into the details of side effects and so forth, or complications. There were very, very few. And certainly the results by themselves were very significant. In terms of the posterior left pericardiotomy, was highly effective. This is the summary in the Lancet, in reducing the incidence of atrial fibrillation at surgery on the coronary artery, aortic valve, or ascending aorta, or a combination of such surgical procedures. Well, Joe, I go back to you. You like to do this? Have you done this? Do you think this is meaningful? At least the results here appear to be interesting.
So I'm conflicted. I'm a co-author on this study, but it wasn't my idea. So I'm allowed to say it's an ingenious idea. It's not intuitive. We don't like making holes in areas that we don't need to, but to reduce AFib by nearly 50% with a very, very simple technique that didn't seem to be associated with any adverse events in a reasonably well-sized trial. Kudos to the Canal Group and Mario Gaudino for showing this. Maybe this is something that will gain traction.
Yeah. Other comments, Athena, what do you think?
Yeah, I would agree. It's a problem that we see clinically, and to have hopefully a simple and low risk and safe procedure that the surgeons can do that reduces that. It reduces length of stay and complications.
Okay, Usha, you are an expert in the field of atrial fibrillation. What do you have to say here?
I think it's really interesting. I think it's fantastic. And I think it may have also this very accidental benefit in the location where the pericardotomy was performed. Mina Chung brought this up in the discussion that they had, that it's basically anterior to the left pulmonary veins down to the mitral annulus, which is right where the ligament of Marshall runs, which is a target for ablation of chronic atrial fibrillation. And so it may be that the location actually makes some difference as well, that if it actually promotes some little bit of fibrosis in that area or something as it's healing, that may also play a role. So it's very interesting, very simple, and there may be a lot of other surgical procedures where it should be considered.
I mean, speaking as a robotic mitral surgeon, I would love to be able to get to the left side to do that. And I think you're absolutely right. The ligament of Marshall, the proximity may be one of the drivers behind their finding.
Joe, you are going to get very busy, guys, because now you are going to do this kind of thing. Then you are going to close the left atrial appendix to prevent thromboembolism. And at the end, you will have to do the operation you're supposed to do. Alexandra, what do you have to say?
No additional real comments. I think, the data is impressive, and I think, it certainly seems like it's safe. So, to get this kind of treatment effect, I think is great.
Okay, thank you. Let's now go for paper number 5. We have 9, remember. Now we are again on atrial fibrillation. This is the one-stop atrial fibrillation, one-stop AFib. The title of the paper, it came in the Lancet, I guess, yes, is JAMA Cardiology, individualized studies of triggers of paroxysmal atrial fibrillation. Well, this is interesting. This is basically the so-called N of 1 trial, and you go to an individual and you ask to the individual to do something. And in this case is you choose what is the risk factor that you think may lead to your atrial fibrillation. And then you stay, if it is alcohol, I'm going to drink alcohol for a few days. And then you are asked not to drink alcohol. And then you follow, see what happens. This is basically the way that the trial is being approached. Well, basically, this is a remote smartphone mobile application-based randomized clinical trial. So again, we go into technology. This is all done at a distance. And basically, the participants receive instructions to expose or avoid self-selected triggers in a random of 1 week blocks for 6 weeks. And the probability their trigger influence atrial fibrillation risk was really what was all about. They were on and they were off. And then there were a group that were controls. They didn't do anything. They had their monitored for their atrial fibrillation on and off over the same period of time. Well, they look at what happened with the number of episodes of atrial fibrillation. And the second thing they look at is your life changing, your quality of life? Well, I'm not sure in 6 weeks your life is going to change, but anyway, this was a question that they also presented. Well, I will leave you with the results. Result number 1, well, let me tell you what they look at. I'm sorry, caffeine, alcohol, reduces sleep, lying on left side. I didn't know this had anything to do with it, but anyway, large meals, dehydration, cold food or drink. Well, look, they could all choose what they thought could induce their atrial fibrillation. These are the results. Number one, significantly fewer daily atrial fibrillation episodes were reported after one trigger testing compared with controls over the same period of time. So whatever the triggers were, it worked in general. But the most important trigger in this study and in a meta-analysis that was done was alcohol. That's one point. And finally, there was no significant difference in the quality of life. Well, I don't know what you changed in 6 weeks anyway, but I am not surprised of that. Well, Usha, I'd like to know what do you think about, it's interesting because we all talk about triggers, but we don't know what triggers really affect our patients. What do you have to say?
Yeah, it's a really interesting study. I mean, the alcohol question has been asked and answered in a lot of detail by Prash Sanders' group in Australia. Really nice detailed information in the New England Journal to talk about cessation of alcohol and reduction of atrial fibrillation. So that's really well known. There was another study that was presented at AHA, the CRAVE trial, where they were looking at caffeine and found not a lot of effect on atrial ectopy or atrial arrhythmias to avoid caffeine intake. So I think it's so difficult. The triggers for different people are so challenging to pin down. I think that I always tell my patients that early in the process of your AFib, maybe you'll have triggers that you can avoid, but eventually you may have multiple behavioral triggers and you could drive yourself crazy trying to live in a little box, avoiding all the triggers. So I don't know that it's a valid therapy for atrial fibrillation necessarily to try to avoid all of the triggers.
Thank you, Alexander.
Yeah, I would dig in a little bit into the alcohol. I haven't read the paper, so I'm coming a little bit blind, but I would dig into the alcohol trigger and wonder if this is not linked to binging. I mean, there are clear links, right, between alcohol and atrial fibrillation. I think if we can at least tackle that, and I think that would have an impact on the frequency of these events for that specific patient population.
Joe, no alcohol for you, not because the atrial fibrillation, because you operate tomorrow. So, what do you think?
While I love a patient-centered, technology-driven novel trial design, I'd have been a lot more excited about this trial if it hadn't required the patients to decide whether to record themselves on an EKG or not. If they sent everybody a Xiopatch, sure, I'd have been fascinated by the results. This seems a little less reliable.
Except this was not continuous monitoring, the patient decided, so it's a very wishy-washy thing.
Precisely.
Athena, what do you think?
Yeah, I would agree. I was a little concerned about the sort of self-fulfilling prophecy of you have to know that you've had an event, but this is what you've already chosen to be your trigger. So it's a little bit of circular argument. And I'd like to see us working a little harder on the things we know we can change: hypertension, alcohol, sleep apnea, that we know will be triggers, and obesity. So,
okay, well, thank you very much. Now, this paper was presented, the one we just discussed by Dr. Gregory Marcus from the University of California, San Francisco, but has another paper called the CRAVE trial, which I only want to make a comment, and is entitled "The Coffee and Real-Time Atrial and Ventricular Ectopy." The similar approach, except here they talk about days. 1 day of coffee, 2 days is not just 1 week over 6 weeks, it's much shorter. And here there is good monitoring. And I just want to read the final results of this paper, which is as follows. There is no increase in atrial arrhythmias with coffee. They already said this on the previous paper where they were not impressed by coffee. But there are more PVCs. Increases the physical activity. Actually, there is some papers in the literature suggesting that those who drink coffee tend to run in the streets. I mean, this is a reality. This is in the literature. Why? I don't know what the association is of cause effect, but certainly they found this here. But they also found it reduces sleep. That's not unusual, isn't it? So maybe coffee is affecting the ventricle rather than the atrium. What do you think, Usha?
I don't know, but it immediately made me think of, one of the things when we go to ablate people's PVCs, which is we're not doing that to everybody with PVCs, but one of the biggest problems in the EP lab is we can't sometimes make people's PVCs happen. And there are some studies that suggest that intravenous caffeine administration can help to bring out the PVCs. And so I was wondering if this is some of the same suggestion that may be active. I don't know from a pathophysiologic perspective why it should be different with atrial ectopy and ventricular ectopy. Why should it be different?
Anyway, we can drink coffee and then we will be more active physically, but we will sleep less. That's the message of this paper, at least to me. Anyway, let's continue. Or any comments you have about these two papers? If we just make a comment, coffee and alcohol. If not,
I'm a little surprised because of the importance of the question that these are not studies where continuous EKG monitoring was thought to be central.
Yeah, I agree with that. This is a very good point. Thank you. Now we get into antithrombotics. There is a lot there, and there are two papers that we will discuss, and then I will make 3 comments about 3 other papers. Let's go into the next one. The next one is called the Reversit. So we are in antithrombotics now. Effect of bentrasimab on platelet inhibition and hemostasis in patients on ticagrelor with measured bleeding or requiring urgent procedures. Dr. Deepak Bhatt from the Brigham and Women's Hospital is the one who presented this paper. Well, we all know this story. The story is, doctor, I don't want to use these drugs because if I bleed, there is nobody will stop the bleeding. Well, this is with ticagrelor. There's nothing that stops the bleeding with ticagrelor. So here's the question, is that it can be a spontaneous measured bleeding in people who take ticagrelor, or bleeding associated because the patient has to go to surgery, and something has to be done to actually block ticagrelor. And this is the drug, is a monoclonal antibody, ventrasimab, is given intravenously. Is a recombinant human IgG1 monoclonal antibody fragment which binds to free ticagrelor with high affinity and specificity. And actually, I will say that it acts very rapidly within minutes, and actually has a half-life of more than 15 hours. So is a very good drug to be available. And now I'm going to be presenting to you the study. It's basically is 200 patients in a multi-center open label prospective single arm study in which the reversal was necessary for ticagrelor that these patients were taking, either because they needed urgent surgery or because actually they were bleeding while they were on ticagrelor. And then bentrasimab was given. And the questions that they were asked is how rapidly platelets are inhibited. Are they inhibited within 4 hours? And what about the primary hemostasis endpoints? Well, they achieve effective hemostasis within 24 hours if the bleeding stopped or never took place, if there was urgent surgery. So all common sense type of questions related to bleeding. And here are the results. The results is that the use of bentrasimab trying to counteract ticagrelor in an emergency case was immediate and sustained reversal was achieved. Effective hemostasis in the way I described, no bleeding with surgery or stop bleeding rapidly occur in 90% of the patients. So it appears to be a very promising option for ticagrelor reversal. Very good. So Alexander, what do you think about this? Patients actually ask even more than doctors when we give antithrombotic drugs. We never ask this ourselves, who's going to neutralize. We think about plasma, fibrinogen, but here's the story. What do you think?
So I think this has been long awaited, right? I mean, ticagrelor is first line for our acute coronary syndrome patients. And, ideally we give it early when the patients come into the emergency room, but the reality is oftentimes high risk, like non-ST elevation MI will wait. We'll take them to the cath lab and wait because they might go to surgery. We know that, maybe, I don't know, 30 to 40% maybe quote unquote high bleeding risk patients. And the approach there is, without this kind of agent, is to peel back. We're looking at reduced DAPT in these patients, even though we know that there's benefit longer term. And then lastly, I think patients that have bleeding complications, whether it be postoperatively or post-PCI, there's a link with increased mortality. So I think for all those reasons, having this kind of agent that seems to be safe, seems to be effective, I think is sort of a safety net. I mean, I predict once approved, and once we have this kind of agent, will actually change how we approach our patients, because we have the ability to treat earlier and to really take advantage of the full antithrombotic effects of ticagrelor. So I think it's long awaited, and I'm very excited to see it come to my formulary.
Joe, what do you think? You face these cases.
I'd probably take this in the context of rapid CABG, which I think you're also going to discuss, which is really looking at ticagrelor in the context of needing surgery and whether you need to wait 5 days or 3 days. My concern with using reversal agents, which you sometimes need to do in the setting of surgery, is the thrombotic risk, particularly if you're doing coronary bypass surgery. So I will do everything I can to maximize surgical hemostasis and not need a reversal agent. And I'm curious what percentage of patients in this study had thrombotic events.
Actually, they don't mention this. In fact, they were. I can tell you, this was a very low. I look at this, and they talk about ischemic events that were very low. It's somewhere in the paper, but there's no detail.
Because I think if you can safely wait 3 days and do an operation without needing to transfuse a patient, I'm not a strong advocate for aggressive reversal of antiplatelet drugs in the setting of a fresh drug-eluting stent.
Yeah, the events, they are there. Okay, very, very few, in fact. Very few. Myocardial infarction, stroke is all here. Now, it's interesting because in a few minutes we will talk about whether ticagrelor, patients can go to surgery within the first 2-3 days of discontinuing or later, but as you mentioned. But anyway, I think the paper is of interest because this is we face such a situation. Any other comment by any of you, Athena, for example? Do you have any comments?
I think it's important to have something in our armamentarium because we really didn't have anything except giving other blood products.
Yeah.
And it also emphasizes to back up and prevent the problem, particularly around GI. I think we've learned a lot that there is a high-risk group that we could collaborate with our GI colleagues and do a little better on the prevention side.
Usha, any comment to add? Okay, thank you. Well, there is a second interesting drug. This is the AXIOMATIC-TKR investigators with the title of the paper, milvexian for prevention of venous thromboembolism. Dr. Jeffrey Waits from Canada presented this paper. This is a drug, milvexian. It has been a talk for the last 3 or 4 years, actually. It's a potent and specific molecule that inhibits factor 11A that we never thought about in the clotting system until very recently. It's rapidly absorbed after oral administration, and it's a half-life of about 8 to 14 hours in healthy volunteers, and is metabolized in the liver less than 20% renal clearance. Well, this is the hypothesis here. There is preliminary data that preoperative factor 11 knockdown and postoperative factor 11 inhibition may be superior to enoxaparin for venous thromboembolic prevention. There's some data in the NEAPAS taking this approach of neutralizing factor 11 may be quite interesting. So the hypothesis of work of this presentation is that milvexian would reduce the incidence of postoperative venous thromboembolic disease in patients after elective knee arthroplasty, and they compare this with actually enoxaparin. That's basically the study. Now, what they use is different dosages of this milvexian, several types of dosages here, And then the primary efficacy outcome was venous thromboembolism. In some patients in which there was not certainty, venography was required. So it's a very well done study in terms of objectively addressing the issue of venous thromboembolic disease. And the safety outcomes is addressing bleeding in different ways. The results are interesting because there are certain dose of this drug given orally, 50 milligrams, 100 milligrams, or 200 milligrams, in which the incidence rate of thromboembolism was less than by giving enoxaparin. So I think this is interesting, although in my view, the dose of enoxaparin of 40 milligrams was relatively low. Safety outcomes, very good as compared with enoxaparin. And actually, the most important is that the conclusions of the study is that the postoperative factor 11A inhibition with oral milvexian is effective for venous thromboembolic prevention and is associated with a low risk of bleeding. And they say milvexian is a promising new oral anticoagulant currently undergoing phase 2 evaluation for secondary stroke prevention. They don't mention enoxaparin in the conclusions, and I think it's because the dose they gave was actually relatively low. So there are still issues of dosage here, but certainly it's an interesting new approach that it has been discussed over the last 3 to 4 years. So what do you think, Athena?
Well, I think it's important to have something else in the armamentarium. And so here's a new drug and they've looked at the correct dosing. It may be particular for total knees where they occlude, above the knee and so they're at increased risk. They have a pretty high DVT risk. And the question is, with the bleeding risk being low, that they can add this in a phase 3 trial to show that they really reduce the risk without any increased bleeding.
Yeah, thank you, Usha.
I guess I would agree with that too. And I think that prevention of thromboembolism after multiple other procedures could be looked at as well, because that's certainly a major complication after many different types of surgery.
Okay, Joe?
The thing I kind of would like to see is agents that treat patients that aren't currently well treated by enoxaparin, and this drug doesn't seem to be suitable for patients with a lower creatinine clearance, previous thromboembolism, anybody on anticoagulation, and that's a population of patients that we struggle with. So really well designed, important trial. We'd love to see agents for patients that currently aren't well served.
Okay, Alexander?
Yeah, so to me, the potential benefits of this agent may be compliance compared to enoxaparin. It's PO versus sub-Q. Potentially lower bleeding risks. It's yet to be proved. And does it have a better, can we treat patients with chronic kidney disease? And what is that threshold? So I think those are the 3 areas that may be of benefit with this agent. And of course, we're going to have to see bigger trials.
I agree. Is some hopes, and it's an oral agent, so interesting. I'd like to make 3 comments about 3 papers very quickly. The first is about the ASCENT study, effects of aspirin on dementia and cognitive impairment in the ASCENT trial. Dr. James Armitage presented the study. And I'd just like to comment that this is a study of patients who are diabetics. That's why they were able to use aspirin, and they compare with placebo in 15,000 UK patients with no prior cardiovascular disease. A follow-up was long, 7 years. And the question is how they measure dementia is an issue here. It's complicated. There is a broad dementia outcome. They say patients who had significant dementia, significant delirium, medications, referral to clinics. And these are easily identifiable because they go or they are hospitalized. A narrow dementia outcome, which is dementia which is less significant, more difficult to know. And finally, they look at cognitive impairment by telephone calls and so forth. And actually, the conclusion of all of these is that aspirin not only not only is not bad for dementia, actually, compared with control, and in fact could be better in decreasing dementia than compared with control. But it's very tough the way dementia is being measured here. So I wouldn't like to go too far here and say, begin to take 1 aspirin a day because you will be brighter tomorrow. I would be very, very careful here. So I think the endpoint is to me, is a little bit loose in 15,000 patients. The second study is actually the one we mentioned before, rapid CABG, a randomized study of early versus delayed coronary artery bypass surgery among patients with acute coronary syndrome treated with ticagrelor. Very interesting study, because here what they did is they compare 2 to 3 days of ticagrelor on people who require urgent surgery following acute coronary syndrome. So these were patients with really troublesome left main disease, bifurcation disease, and it's about 5 to 10% of patients that might require actually bypass surgery very early, and they are in ticagrelor. And what they found is no difference if you have off ticagrelor for 2 to 3 days as compared with 5 to 7 days. Joe?
Well, this is like any small, relatively underpowered trial addressing an important question. If the results concur with my practice, it reinforces what I do. In this case, I don't usually wait longer than 2 or 3 days. I'm guided by platelet assays. But to convince surgeons that are nervous and want to wait 5 days, it obviously needs a bigger, better powered trial, because the number of events that would switch the findings are very, very small.
What is interesting is the bleeding was exactly the same, and the transfusion, there only was more platelet transfusions in the group that was early, but all the rest, the red cell transfusion, bleeding, and so forth, no difference.
Yeah, the primary endpoint's a bit of a blunt instrument that they went with. I think it was massive transfusion of 5 units, 5 grams or more drop and 5 or more units. And I think that's a fail if you've got to that point. We're all trying to get these patients through coronary bypass without any blood products. You can do it safely in 2 to 3 days if you're guided by platelet assays real time. Individualize it for your patients.
Okay, thank you. The final comment is about the paper with the use of P2Y12 inhibitors in non-critically hospitalized patients with COVID. They did nothing. It didn't work. This was a part of the NIH study in which they are using several antithrombotic agents, was presented by Jeffrey Berger, but certainly there is no role for such platelet inhibition in the time of COVID. I want to actually finish with what I said. We talk about valvular heart disease, heart failure, atrial fibrillation, and cardiac arrhythmias, antithrombotics, and now 2 extremes of cardiovascular disease. The last 2 studies, I like a comment, what do you think? One is called the DREAM-HF trial, which mesenchymal precursor cells, all of these in heart failure. And the other is to prevent at a distance hyperlipidemia and hypertension. I call these 2 extremes in our business. But let me go about the first one, which is the DREAM-HF trial. I really don't know what to say. I like your opinion, but basically, as you know, mesenchymal precursor cells have a number of ingredients that may be very good for the health, and they come from the bone marrow. In modulation, proangiogenic, and so forth. And they have been tested in animals with heart failure, and they appear to perhaps do something good in a field of tissue regeneration that things have not gone up until now, at least in the way they should be. They were actually, these were patients from 18 to 80 years with chronic ischemic or non-ischemic heart failure, New York Heart Association classification 2 or 3, and they were stable heart failure, and the ejection fraction was below 40%. There were 537 patients that were randomized and treated. Half of them received the mesenchymal cells and half of them didn't. More patients were in class 3 of the New York Heart Association than in class 2, but I just like to go directly to the results. The primary endpoint was recurrent non-fatal decompensated heart failure events per 100 patients. the cumulative rate, and actually no difference between the patients who receive mesenchymal cells versus sham control patients. They find differences on something that I don't know what this has to do with heart failure, in non-fatal myocardial infarction or non-fatal stroke. Is interesting. And certainly also in cardiac death, particularly in patients with class 2 of the New York Heart Association. And then there was some benefit in patients who had inflammatory markers in the blood. So the results of such enterprise is that mesenchymal precursor cells did not reduce cumulative recurrence of non-fatal decompensated heart failure events in patients with persistent heart failure with reduced ejection fraction. This was the main point. But then they talk about non-fatal MI or non-fatal stroke may be helpful. Patients in class 2, perhaps cardiac death may be helpful, or perhaps when there are inflammatory markers of CRP. I don't know what this means in terms of practicality, because for the last 20 years, we have been dealing with repair of the heart and with not great success. Athena, what do you have to say about the study?
Well, kudos for a carefully done study to try to look at this problem again, because there is a lot of hope buried in there. The challenge is a little concerning because we didn't see any heart failure benefit, but we saw mortality benefit, which is unusual. So I'm not sure exactly what the mechanism behind some of that may be. So I think more questions than answers in some ways.
Usha?
Yeah, it's so tough when you see a result like that, that you can't really put together the biological plausibility. You know, a lot of other things we've tried to put into the myocardium of patients with heart failure directly, like skeletal myoblasts and things, have increased ventricular arrhythmias. And so I don't really know what to make of this.
Alexandra?
So, you know, I think it's a relatively heterogeneous patient population. I think that may be one of the issues. And of course, I mean, they missed the primary endpoint. And I think, you know, we need to stop there. And, you know, my sense is that we're digging into secondary endpoints and we're finding some differences in subsets. And I think that may be helpful for these investigators to take this to the next level, to, if given funding, of course, you know, to narrow down the patient population and to better define their endpoints. And I think that's the key takeaway that I have from this study.
Certainly there is a movement now, rather than the cells, it's the product of the cells that can enhance a number of biological processes. This is a significant change. Joe?
I think you're absolutely right there, that there's a move away from cells to the biosphere. And two, yes, it would be great if these guys get funding to explore it with a better sense of what the mechanisms that drive the outcomes, the clinical outcomes that they're showing in graphs that really at 1,500 days have only 4 or 5 patients left at risk.
Okay, thank you very much. This is the last paper. Maybe I will make it more as a comment because it is entitled Digital Care Transformation, report from the first 10,000 patients enrolled in a remote algorithm-based cardiovascular risk management program to improve lipid and hypertension control. Well, this is another case in which this is all done at a distance. And we know how difficult it is to control hypertension and how many patients take the drugs. The same for hyperlipidemia, maybe 50% do and the other 50% do not. And the question is, what can be done? And maybe there are methods, they suggest, methods done virtually at a distance that may work. Well, this is actually a study. Patients were identified by a provider or electronic health record of having hypertension and LDL cholesterol, in which the patients should follow guidelines to be optimized. And the management of hypertension and of hyperlipidemia was by the Wi-Fi, Bluetooth devices, etc. And it's very interesting. Again, it's all done at a distance. And I could go into all the details, except to say that from the screen 28,000 patients, at the very end, only 2,700 actually in the lipid group actually had maintenance of what was given properly, and only 44% of the group of only 1,400 in the group that was actually treated for hypertension. So I want to repeat this because it's important. 28,000 individuals are approached. And at the very end, you end up with 2,500 or 1,400. So it's a difficult task. That's the first point I want to make. The results were interesting. Certainly, there was a drop in blood pressure of systolic 10 to 12 millimeters and diastolic 6 to 7 millimeters from baseline. And these actually happen in all the different groups: white, black, other race, Hispanic, non-English speaking, and so forth. And in terms of hyperlipidemia, it was a drop from LDL 145 milligrams DL to about 100 milligrams DL. And again, this was actually in a way across all racial, white, black, etc. And I think this is interesting. But then they conclude, we found a method that is going to work. Well, I will tell you the following. We have done the same thing in 4,000 patients. And let me tell you what the problem is. To do an individual approach is expensive. And actually, I can prove this to you by telling, just see if I have here something that could be of interest to you. There were 100,000 phone calls, lab evaluation 74,000, new prescriptions 27,000. This is very expensive. So it's not like this is a cheap. The only group therapy is less expensive, and I don't get into the details, but the main problem is sustainability. All the studies we have done in adults, in children, you reach a certain stage of excitement, and then it goes down. The hypothesis, the secondary intervention may be fantastic, will be exponential, but this is the reality. So I would say this is a great study. It's just a comment. It's a great study, but I will tell you, this is not cheap. And the other issue is the sustainability is a real problem of all these studies. And our hypothesis now of work is to reintervene. Comments that you have about something like this, maybe Alexander?
Yeah, I wonder, I mean, your point is well taken. You're starting with a very large cohort of patients and then narrow it down to a tenth. But I wonder if there's not a cohort of patients who are amenable to treatment using this remote approach. I mean, there is a cohort of people that are very much addicted to their cell phones and apps and iPhones. And I just wonder if there's not a way to identify who those patients are, and then we can kind of like, treat them through this mechanism. I don't think it's for all. I totally agree that it's very labor intensive. I think it would need to be refined to be broadly applicable. I think this has a long ways to go. But kudos to the group for really looking at this.
Thank you. Usha?
I agree. It's sort of like a feasibility that if you have this group, then there's a chance that you can help them. But I think that the generalizability is a really big problem, that different populations may not have access and they may not be able to comply.
Thank you, Joe.
It maybe speaks to our failure to make patient education and generalized care more accessible. I'm sure these apps looked great on a PC and made sense in a clinical environment. But if you think about how most people use their phones and access information, we kind of need to make it very different, low friction, almost gamify it, I think, to get the kind of traction that will really make meaningful differences for people.
I like the word education. Athena?
Yeah, I think that using the financial aspect is we now have renal denervation and other new technologies coming along. And so making this personalized for some groups, that may be the choice, whereas others having an approach where they essentially have a coach who's calling them, which I think the equivalent and also the downstream effects or costs, if you will, of the negative effects of not controlling high blood pressure and not controlling cholesterol could be taken into effect, assuming the insurers would choose the one choice over another.
Okay, thank you. But certainly, you see, we had 4 papers in which things were done at a distance, Joe, something you mentioned at the beginning. Well, look, 1 hour and 15 minutes, exactly. I have a final question for each of you. Which one of these studies you think that you carry a message home that is going to change you in the way you practice? I will ask, start from on the screen from left to right, Alexandra.
I have to say I like the AVATAR trial. I don't know that that can be implemented in the immediate because we need guidelines, but I think that's highly impactful.
Joe?
You had 4 terrific surgical trials, incredibly low mortality, great outcomes across the board. Maybe it's a tricuspid one, intervene less, wait for moderate or severe tricuspid regurgitation, and do a better job at avoiding pacemakers.
Usha?
I think it has to be the posterior pericardiectomy. I think that's the great results from a very simple intervention.
Athena?
I'm going to choose the AVATAR trial as well, because I think this is a challenging group of patients. And if we narrow down that group that could really benefit from early intervention, it will be very helpful.
Okay, if you're asking me what the trial that I like it the most, is that we were 1 hour and 15 minutes with 4 colleagues that were fantastic. This to me was the best. I really appreciate it. I think this very difficult to actually deal with 16, 17 trials here on a period of time, and you were so succinct and nice. I really appreciate it very much, and thank you. It certainly is not the last time that you come to this program. I think is quite rewarding, and I think the discussions were quite informative. Well, thank you very much, and I wish you the best. And for the audience, of course, I hope you were 1 hour and 15 minutes, that you had some break and maybe you learned something. Thank you all. Thank you.